students to join before we start our discussions.
Okay, sir, sure.
Dan Marcus sama apa dan Mama bayar phone kamu. Apa? Lawan.
Okay, I think we'll start the session.
Sure, sir.
Good evening, students. Today I thought we'll have a case discussion. I was planning to have a spotter session, but I thought it is today also we'll have a case discussion, and next week we'll have a spotter session. So I need somebody to discuss the case. Any volunteers? Any volunteers who would like to discuss the case? I'm really surprised that nobody is volunteering, because it is an opportunity for you to discuss the case so that you gain confidence. And ultimately, when the real examination comes, you can walk through the examination, because you have gained so much confidence in discussing the case that any case can be discussed, and you can actually come out with flying colors. So it's very important to volunteer and discuss the case. Anybody who would like to do that? I prefer some final third year students to discuss, so that they are the people who have to appear for the examination. Rishikesh, are you a final year student? Rishikesh. Jagadish.
Yes, sir.
Jagadish, are you a final year student? Third year?
Yes, sir.
Hello, Jagadish. Hello? Am I audible to you?
Yes, sir. Am I audible, sir?
Are you a final year student?
Yes, sir.
Okay. So where are you from?
Sir, I am from Mumbai, sir. Just local.
Just look. Okay. Right. Okay. So we'll discuss a case. I will share the screen with you.
Okay.
Is my screen visible to you?
Yes, sir.
Okay, good evening. I'm sorry about that. Something happened to my computer.
Yes.
Jagdish, are you ready?
Yes, sir.
Okay. So I will try to share the screen. Okay, is my screen visible to you?
Yes, sir.
Okay, so we'll go with the case. So, okay, right. Jagdish, start.
Here is a 78-year female. Sir, am I audible clearly?
You're reasonably audible to me, but if you can make it slightly better, I think that would be great. But you are reasonably audible.
Okay, sir.
Okay.
Here is a 78-year female presented with complaints of exertional breathlessness since 45 years. History of presenting illness. Patient developed exertional breathlessness, NYHA class 2, during her second pregnancy at around 6 months, that is 45 years ago. There is no history of paroxysmal nocturnal dyspnea, and there is no edema of lower limbs, and there is no palpitation, and no cardiac pain, syncope, or hemoptysis. Her obstetrician referred her to a cardiologist who, after clinical and ECG examination, told her that she is having heart disease from birth and that at present she is stable and unlikely to have any problems during pregnancy or delivery. Her cardiac condition remains stable and she had uneventful delivery. She remained asymptomatic, excepting breathlessness on strenuous activities, no PND at any time, no edema of legs. She was on regular follow-up once a year. No treatment was prescribed. No surgical treatment was suggested. About 15 years ago, she had an episode of weakness of face and upper limb, that is on left side, from which she recovered completely within a day. 10 years ago, she developed irregular palpitation and had associated increase in her symptoms. She was hospitalized and medicines were injected through her vein, and after some time her palpitation subsided and she felt better. She was given medicines to prevent clotting of blood, which required periodic blood test and adjustment of doses. After 1 year of treatment, she underwent 24 hours monitoring of her beat, and based on that, her medications were stopped. No history of exertional syncope, bluish discoloration of fingers and toes, or thickening of fingertips. She was detected to be diabetic 10 years and hypertensive 8 years ago. She is on treatment for both the conditions.
Okay, go ahead.
Past history? Yes, sir.
You finish the history part, then you discuss.
Yes, sir. Sir, here is that is 70.
No. You can finish the past history, family history, all those details. Then then discuss.
Okay, sir. Past history, no past history suggestion of rheumatic fever, and born full-term normal delivery, no consanguinity in parents, no heart lesions was detected at time of birth, which was home delivery. Family history, no history of congenital heart disease in a family, no history of maternal medication during pregnancy. Both her parents had diabetes and hypertension. She had two children with full-time normal delivery. First pregnancy was normal 52 years ago, and she attained menopause at 50 years of age. And personal habits, she no habits.
Okay, now you will discuss the story.
Yes, sir. The elderly lady, sir, presented with exertional breathlessness. And NYHA class 2 during her second pregnancy at around 6 months. 6 months, that is 45 a year ago.
Why do patients develop symptoms during pregnancy? Why do patients heart disease develop symptoms during pregnancy?
Sir, pregnancy is being volume overload conditions.
Okay. What are the hemodynamic changes of pregnancy?
Sir, during pregnancy, there is a increase in blood volume, sir, maternal blood volume by if a single pregnancy by 1 liter, sir. If twins are there, if it is then about a 2 liter cardiac output will increase compared to normal baseline cardiac output.
Okay.
And in pregnancy, recalcitrant lesions are tolerated well, sir, and stenotic lesions will cause a.
No, you tell me all the hemodynamic changes of pregnancy. You said there is increase in the cardiac output. Yes, what else?
And sir, increase in blood volume itself, sir.
But increase in the blood volume. Okay. Yes. What else? There's increase in the blood volume. Increase in the cardiac output.
And in third trimester, sir, as baby grown, there is a pressure over the vena cava and the aorta, sir.
No, tell me all the changes in the cardiovascular system that can happen associated with the pregnancy. You said one, increase in the cardiac output, increase in the blood volume. What else?
There is hyperdynamic circulation, sir.
Yeah, hyperdynamic circulation is due to what?
Due to that is increased blood volume and
more important than that, there is associated reduction in peripheral.
Reduction in systemic vascular resistance.
Yes, systemic vascular resistance is brought down, the vessels dilate, and especially the biggest influence of peripheral vascular resistance reduction is because of which part of the blood vessel? Which region actually contributes to the peripheral vasodilation or peripheral vascular resistance reduction?
Dilation, sir, dilatation of peripheral vessels.
It does happen, but which is the region which is maximum affected, where there is maximum vasodilation? There is some disturbance going on. Yeah.
Yes,
Can you rectify it?
sir, actually, it is from the Jagdish sir itself, himself, sir.
Beg your pardon?
It is coming from Jagdish, sir.
No, there is some noise coming on.
Actually, I'm in hospital, sir. That's
Some disturbance. It
Yes,
interferes
yes.
with the teaching program.
yes.
Can you, is there anything that you can do to rectify that disturbance?
Yes, sir. I'm.
Okay, I think now it is
Okay.
better. Okay.
Yes.
So, the region which actually contributes maximum for the reduction of peripheral vascular resistance is placental circulation. It is a placental
Again, sir.
circulation where there is maximum reduction in the vascular resistance, and that contributes to significant reduction in the vascular resistance. Of course, other parts of the body also will be partly affected, but the maximum reduction is because of the placental circulation. Why it is so? The nature has done it very carefully, very intelligently. What is the reason?
Sorry, sir. Placenta. Sorry, sir. I didn't.
Beg your pardon?
I didn't get, sir.
See, when you look at the systemic vascular resistance reduction in pregnancy, the
Yes, sir.
maximum reduction is in the placental circulation.
Yes, sir.
Other parts also may dilate partly because of the hormonal influence, but the maximum effect is on the placental circulation. Why
Yes,
is
sir.
it that nature has created such that the placental circulation is the region with maximum reduction in systemic vascular resistance?
Sir, basically some hormones are secreted from the placenta, sir.
Yes.
Because of that local hormones and that causes reduction in systemic vascular resistance.
Well, that's right.
Basically,
The placental circulation is having the lowest vascular resistance in pregnancy in order to have the maximum blood supply to this region. Then only there can be adequate nutrition of the fetus. The fetus can grow well, and that is why there is plenty of there is significant reduction in the vascular resistance in the placental circulation, resulting in profound excellent flow through the placental circulation, so that the fetus gets adequate nutrition. Okay, right? Yes. So
yes.
the systemic vascular resistance comes down. Yes. What else? So you said there is increase in the blood volume, increase in the cardiac output, decrease in the systemic vascular resistance. What else? Increase in
Heart rate will increase.
heart rate. There is an increase in the heart rate. In general, you can think that everything increases by about
Stroke volume also increases.
stroke volume also increases. There is about
Yes.
4 increase and one thing can come down. You can roughly say that everything changes by about 10 to 20%. Heart rate can increase by about 10 to 20 beats. The cardiac output can increase by about 10 to 20%. The
10 to
stroke volume can
15%,
also
yes.
increase by a similar quantity. And the blood volume also increases by about 10 to 20%. And systemic vascular resistance comes down. And
Yes,
when
sir.
is the maximum change? When you in which stage of pregnancy there is a maximum hemodynamic change?
During third trimester, sir, during labor.
Or third trimester?
Second trimester, sir.
Towards the end of
Second stage of labor. Second
24th
stage
to
of
28th week. That
Yes.
is the time when the maximum hemodynamic changes take place, 24th to 28th week. Subsequently, there is no more changes in the hemodynamics of pregnancy. Maximum is around 24 to 28 weeks. That is why these patients become symptomatic by around that age. If you classify the heart disease, can you tell me heart disease where the pregnancy is contraindicated? Then heart disease where the pregnancy can significantly deteriorate the condition of the patient. Third, the heart diseases where the pregnancy sometimes can create problems, but most of the times they can continue with pregnancy. And finally, heart diseases where there is no problem of pregnancy, they can continue to have normal pregnancy. Can you tell few conditions where contraindicated?
So cyanotic congenital heart diseases.
Very good. Cyanotic congenital heart diseases.
Yes, sir. And cyanotic congenital heart disease with Eisenmenger, sir.
Yes, Eisenmenger syndrome. Yes, very good.
And stenotic lesions like mitral stenosis.
Before that, you can also include primary pulmonary arterial hypertension. Primary pulmonary
Yes,
arterial hypertension is also a condition where the pregnancy is contraindicated. One more. Any one of you, any one of the students can answer that.
Severe AS, symptomatic severe MS.
Yeah, severe, of course, severe MS and severe AS. Well, because severe MS now we don't consider it as a contraindication for pregnancy because we can still rectify it by doing a balloon valvuloplasty. So I would say that it is a where the patient can deteriorate. Before that, you should include one more condition in Marfan syndrome. Can you
yes, sir.
complete the next sentence?
Yes, dissection and
Eh?
Dilated aortic
autopathy. So mainly
Yes,
autopathy.
very good. Patients with Marfan syndrome, where the aorta is more than 4 centimeters in diameter. Why it is
Yes,
contraindicated?
sir. Due to stress of pregnancy, that may cause aortic dissection and maternal complications.
Yeah, these patients with Marfan syndrome has cystic medial necrosis. They are predisposed for aortic dissection. And pregnancy also is a condition where the collagen tissues become actually very loose. And on top of the already loose collagen tissue in Marfan syndrome, the pregnancy can contribute to further loosening of the collagen tissue. And these patients are prone to aortic dissection. So the risk should be especially explained to the mother, the husband, and the parents of the girl before pregnancy is allowed. Because those patients with Marfan syndrome, where the aorta is not involved, where the aortic size is only less than 3.5 centimeters, you can allow the patient to have normal pregnancy, no problems. But if the aorta size is more than 4 centimeters, then it is the pregnancy to a large extent, I would say, is contraindicated. So every Marfan woman, before she becomes pregnant, should have a proper echocardiographic evaluation to assess the size of the aorta. Okay. So these are the few conditions where another condition where there can be a problem is coactation of aorta, but that can be tackled during pregnancy without much problem. Okay. Conditions where the pregnancy can significantly deteriorate the clinical status. Conditions.
Again, sir, mild mitral stenosis, sir.
Not mild, mitral stenosis. The mitral stenosis can
Yes.
significantly deteriorate during pregnancy. Why? Why it deteriorates? Why? So you have to think of hemodynamics of pregnancy and
So because
correlate
of
with.
tachycardia, sir, there will be, and also, sir, there is a increased volume overload also.
Okay.
Both the things, sir, will increase, sir, diastolic feeling of the left ventricle, and also, sir, pulmonary venous hypertension will develop.
That will increase the filling of the left ventricle. When the heart rate increases, when the
Sir,
heart
because
rate
of the heart rate increases, diastolic time will decrease.
yes,
So,
that's
sir, mitral stenosis will be augmented.
yes. So in a patients with mitral stenosis, when there is increase in the heart rate, the diastolic time comes down. The time to fill the ventricle comes down. That will result in stagnation of blood in the left atrium in a patient with severe mitral stenosis. resulting in pulmonary congestion and development of pulmonary edema. Okay, right. Yes. So that's the most important point. And further, the increase in the stroke volume, increase in the cardiac output, and increase in the blood volume also contributes. But the increase in heart rate is the most important point. Very good. Yes.
And sir, one more thing, sir, pregnancy is also a little prothrombotic. So though it is not directly affecting, but sir, we should think about that also.
I don't know whether pregnancy during the early part, whether it is prothrombotic or not. Usually they become prothrombotic towards the late half. Towards the actually this could be a protective phenomenon because when the woman gives birth to the baby, further bleeding can be prevented because placenta is a very vascular tissue and it may be about nature's protection. And usually the prothrombotic tendencies are more towards the third trimester.
Yes, sir.
Okay, right. So a few conditions where pregnancy sometimes can cause the patient to deteriorate, or sometimes they may tolerate the pregnancy very well. One or two conditions.
Repaired VSD and ASD.
VSD, small VSD, not a problem. Mild lesions, all mild lesions, actually there is no problem of woman becoming pregnant.
Regurgitant lesions are tolerated well.
Yeah, regurgitant lesions are well tolerated. Before that, hypertrophic cardiomyopathy. What happens to hypertrophic cardiomyopathy?
Diastolic dysfunction.
Sir, there are two opposite phenomena happening here. Because sir, there is a decrease in the peripheral vascular resistance. Then sir, we should think that the gradient will increase. But
Very good.
because sir, volume is increasing, which will be sir decreasing the gradient.
Okay.
So it will be sir little nullified.
What about the contractility?
Yes, sir, contractility will also increase. Sir. So
Yes.
two things are increasing.
Two things increase the gradient and one
Yes,
thing
sir.
will reduce the
Gradient.
Okay. So in general, most of the patients of hypertrophic cardiomyopathy can tolerate the pregnancy, but those patients who have got significant obstruction, sometimes they may deteriorate because of the significant effect of this afterload reduction. So you have to give a caution to these patients that there is a possibility that you may deteriorate. And some of these patients, when they deteriorate after the third trimester, after the first 3 months of pregnancy, you may give a small dose of beta blockers, which can reduce the heart rate, which can reduce the contractility, and they may tolerate the pregnancy extremely well. What is the problem of beta blocker in pregnancy?
So intrauterine growth retardation.
Very good. As you can give rise to intrauterine growth retardation. So that should be told to the parents that there's a possibility that there can be some growth retardation, but then you know it may not precipitate any congenital anomalies on the fetus. So hypertrophic cardiomyopathy patients, most of them tolerate pregnancy without any problem. But as Saroj has rightly pointed out, because of the reduction in systemic vascular resistance, which can increase the outflow obstruction, there's a possibility that some of these patients can actually deteriorate. Okay. Where the lesions where the pregnancy is well tolerated?
It's a regurgitant lesion, sir, like mitral regurgitation.
Mitral regurgitation.
ASD, sir.
And ASD, very good. ASD is a well-tolerated lesion, and there is no contraindication for pregnancy in a woman who is having actually a septal defect. Of the two lesions, mitral regurgitation and aortic regurgitation, which is better tolerated?
Mitral regurgitation.
Aortic regurgitation.
Aortic regurgitation. Aortic regurgitation is better tolerated. Can you explain, Patel? Jagdish, can you explain why the aortic regurgitation is better tolerated than mitral regurgitation? See, whenever a question is asked, you should immediately think about the hemodynamic changes and think whether can I explain the difference between the aortic regurgitation and mitral regurgitation on the basis of hemodynamic changes of pregnancy. That's the way you have to think. Anybody can answer. Somebody wants to
pulmonary venous congestion.
There is some noise.
Yes.
Prayag, I think there is something wrong with the connection today.
MR will have more chance of pulmonary venous congestion.
Beg your pardon? MR will have?
Sir, because of systemic vascular resistance is decreasing, that's why, sir, AR will be lesser.
Yes. One, there is a decrease in the systemic vascular resistance, and because of that, there's more of forward flow, and AR become less significant. 1, 2. What about the increase in heart rate?
So then also, sir, diastole is decreasing, then, sir, AR will decrease. Sir.
Yes, there is a diastolic time will come down, so AR will decrease. Increase in the contractility and increase in the venous return. That also will favor because there can be more forward flow and the patient can tolerate aortic regurgitation very well. What is the problem with mitral regurgitation?
So because of the volume overload, there is a more chance of, sir,
What is the effect of heart rate on mitral regurgitation?
sir,
When there is an increase in heart rate, which phase of the cardiac cycle becomes longer?
so systolic become longer.
Systolic
So,
becomes
sir,
longer. What
mitral
will happen to
regurgitation will
mitral
deteriorate.
regurgitation? Mitral regurgitation become
Will increase, sir.
increase. So of the two lesions, aortic regurgitation is better tolerated than mitral regurgitation. And ASD is a lesion which is well tolerated during pregnancy. So this patient became symptomatic when she conceived about 45 years ago. Jagdish, would you like to think about what are the conditions? And also her cardiologist told her that you don't worry about it and you can easily go through the pregnancy. So from that, can you
Sir,
draw few conclusions?
this condition suggests about, sir, atrial septal defect, sir.
Atrial septal defect. Okay. Is there anything which you make you think that this may not be atrial septal defect from the story?
No, sir, because like all pointers is most favorably towards
Yes,
atrial
I
septal.
agree with you that ASD should be considered as a strong possibility because the
Yes,
pregnancy is
sir.
well tolerated and
Because there is
there's no,
arrhythmia is also there.
yeah. But there's something which makes you think that this patient may not be having ASD.
Sir, possibility of MS, sir, because she presented at the age of 35 years with a history of pregnancy worsening the breathlessness, and then history of CVA.
Oh, so you think
and history of DC version and oral anticoagulation.
Okay, so she might have developed atrial fibrillation. So, but there is no history of paroxysmal nocturnal dyspnea, nothing to suggest that this could be definitely mitral stenosis.
Yes, sir. Sir, in this 45 years history with mitral stenosis, at least she might have one episode of PND or obstructness.
Yeah, I think 45 is a long period for a woman who has become symptomatic, and then unless it is very mild mitral stenosis.
Sir, mitral valve prolapse.
Okay, mitral valve prolapse is a possibility. Very good, excellent. Because women may present with a mitral valve prolapse, and then that is well tolerated, and there may not be much of a problem. Yes, very good. Yes, atrial septal defect is a possibility. Yes. Only point against the atrial septal defect is that her treating doctor did not suggest to her that she should undergo either a surgical procedure or a device closure. Of course, 45 years ago, probably the advice would have been more of a surgical closure, but there was no advice given to her that she has to undergo a surgical treatment. Maybe after her pregnancy, everything has settled down, but that was not told to her. Okay, right? Yes. Do you think that this could be a case of VSD?
Sir, VSD also, at least she should present with the volume overload symptoms like palpitations or anything. So maybe small muscular VSDs.
She was 32 years when she was detected to have, when she became pregnant for the second time. So, VSD, what is the natural history of VSD? At what age does the patients with VSD, we look at a VSD, small VSD, moderate VSD, large VSD, what is the pattern of their disease progression?
Sir, large VSD, sir, usually they will present with, all VSD will present with recurrent respiratory tract infection in childhood,
Yes,
sir.
early childhood, they will have a respiratory tract infection. Very good.
And large VSDs will go for SN migration at the age of 21 years, sir.
Yeah, second decade, towards the second half of second decade, they can go for Eisenmenger reaction, and they may present with Eisenmenger reaction, pulmonary arterial hypertension. Yes, one. Two.
And small and moderate, small VSDs can tolerate.
Large VSD, can they become smaller in size?
Yes, sir.
Percentage.
Percentage.
Large VSD is around 10 to 15%, actually can
5 to
become
10%.
smaller, significantly smaller. What are the mechanisms of closure of the VSD or decreasing size of the VSD? How do they, how does the VSD close? Mechanisms. Jagadish, what are the mechanisms
Sir,
which VSD close? Spontaneous closure.
Sir, any tissue prolapse causing closing.
No, you cannot use the word any tissue and all. You have to say specifically what tissue.
Sir, the aortic cusp, coronary.
Oh, okay. Aortic cusp, the right coronary cusp may prolapse into the VSD and may partially or may even completely close the VSD. But that is that is at the expense of what? When they prolapse, what happens?
Aortic regurgitation.
Yeah, the patient can have aortic regurgitation.
Yeah.
But so you have to describe situations where the VSD can close and that actually gives a cure.
So sometimes in infective endocarditis, the vegetation can.
Okay, infective endocarditis vegetations can sometimes reduce the size of the
Yes.
VSD. Those are all pathological. Can
Yes,
you tell me something where by a natural process VSD
Yeah.
can close?
Visualization.
Yes, sir. Sir, RBOT, severe hypertrophy.
So that you are saying about the Gasul VSD. Gasul VSD can that can gradually progress towards the and present as something like the tetralogy of Fallot. No.
Oh.
What are the mechanisms?
The muscular VSD may decrease by itself.
Which one?
Muscular
Small
Muscular VSD can decrease, especially during the systolic phase. It may come close together, and in the edges of the VSD can get stuck during systole and may spontaneously close. So the VSDs which close are one VSD, muscular VSD and the perimembranous VSD. The VSDs which do not close are Jagadish. What are the VSDs which do not close?
Inlet VSD, sir.
Inlet VSD and
Inlet and outlet VSD.
outlet means what outlet? Perimembrane also is an outlet VSD.
Subbiotic.
No, not subbiotic. Subbiotic VSD can close. Subpulmonic VSD. Subpulmonic VSD and the inlet VSDs do not close. The subbiotic or perimembranous VSD and the muscular VSD can close. Okay. So one mechanism is that direct apposition. Two, how can the VSD close?
Aneurysm of septum.
Yeah, aneurysm of the septum, very good. There can be sometimes development, the tissue can grow from the edges of the septum. There can be a septal aneurysm, and this aneurysm can finally close the VSD. Excellent, very good. Three.
So sinus of Valsalva sometimes.
No. Sinus of Valsalva, abnormality of sinus of Valsalva will result in prolapse of the aortic cusp, and that can partially close the VSD.
Then, sir, septal leaflet of tricuspid valve.
Very good, excellent. Septal leaflet of the tricuspid valve can get adhered to the VSD, and thereby it can close the VSD. Anything else? Then, as the baby grows, what happens to VSD? If the size is not increasing, but when the baby grows, the heart becomes bigger and bigger, and the relative size of the VSD becomes small. A VSD which is, let us say, 1 centimeter in diameter at the birth is a large VSD. But when the VSD remains the same, the heart increases in size, everything increases in size. Ultimately, VSD becomes a relatively small VSD. So, growth of the baby, growth of the individual can result in a relative reduction in the size of the VSD. Not absolute reduction, but a relative reduction. So these are the mechanisms. So if you are asked a question, you should say, first, there can be a direct appreciation of the VSD, leaf the edges resulting in closure of the VSD. Two, the growth of the fibrous tissue, and aneurysm can be formed, and that can result in closure of the VSD. Three, septal leaflet of the tricuspid valve can get adhered to the edges of the VSD, and a VSD can close. Then prolapse of the aortic cusp can result in closure of the VSD, and infective endocarditis vegetations also can cause the partial or even complete closure of the VSD. So these are the different mechanisms by which VSDs can close, and two VSDs which can close are muscular VSD and the perimembranous VSD. Other two VSDs do not close. Okay, right? Yes. So here, what are the any other condition that you would like to think about? Okay, right. So these are the few conditions that we will think. We think that this could be an ASD, or it could be a small VSD, or it could be a mitral regurgitation, aortic regurgitation, mild lesions, and the patient went through the pregnancy without much problem. Okay. So, all right. Any other clue from the story?
There
What
is
is the absence of PND mean, Jagdish?
Sir, PND rules out mitral stenosis, sir. Condition which increasing left atrial pressure, like mitral stenosis.
Yes.
And or aortic stenosis is the 45 years history with aortic stenosis can present with PND.
At the age of 30, aortic stenosis, is it a male's disease or a female's disease? Aortic stenosis, is it a male disease or a female disease?
More common in male.
It's a male disease. While the in what type of a female there can be aortic stenosis? What is the female who is predisposed for aortic stenosis?
Sir, rheumatic.
Rheumatic, of course. Usually, the mitral valve is more often affected. Aortic stenosis is very rare in rheumatic, very unusual. But is there any
Turner's?
Yes, Turner's, very good. It's a Turner syndrome. A female with a Turner has got a higher chance of developing aortic valve disease. They are also prone to develop, they have bicuspid aortic valve. They can also have coarctation of the aorta. All the aortic diseases are a male disease, and the Turner is a male female, and who can have the male pattern of disease. Can you think of any male with a female pattern? Male who is having a female pattern?
Sir, XXY, sir.
Klinefelter.
Klinefelter, okay, right. Another is Noonan syndrome. Noonan syndrome is occurs in a male, and the patient
Pulmonary
can
stenosis.
dysplastic pulmonary valve and pulmonary stenosis. Okay. So in this patient, the possibility.
Sir, here we have to think the differential diagnosis of ASD. Like, sir, we can think about the PAPVC.
Yeah, partial anomalous pulmonary venous drainage. Very good. Partial anomalous, not total anomalous.
PAPVC, sir.
Partial anomalous pulmonary venous drainage can be definitely considered. Yes. Any other possibility?
Sir, other types of ASD, like, sir, coronary sinus,
unroofed coronary.
This can be character transposition of great arteries.
Yeah. Yes, sir.
Possibility.
Yes, sir, possible, sir.
Without any associated lesion, just character transposition of great arteries.
Yes, sir. Yes, sir.
Yes,
but sir, going up to 78 year of age.
No, she's gone up to 78 years. That's a bit unusual because why? What is the problem of character transposition?
Sir, in that one, sir, usually patient goes into left-sided heart failure because, sir, later on this regurgitation will not be tolerated. Uh, sir, here the regurgitant, sir, LV and RV, they are, sir, at the mm, like not at a proper place. Sir, here LA is draining into RV. And RA draining into LV. So, sir, systemic circulation is exposed, RV is exposed to systemic circulation, which will not be tolerated.
Yes, that's the most important point. You should say the RV is facing the systemic circulation, and the RV is not made to face such a very high pressure. And because of that, over a period of time, these patients can develop RV dysfunction and they may develop heart failure. So the corrected transposition, even though the oxygen carrying blood goes to the systemic circulation, the RV still pumps the blood into the systemic circulation and may not be able to sustain the pumping, and the patient can go for RV dysfunction. Okay, right? Yes.
And sir, one more thing, sir. Here, sir, this history is suggesting, sir, possibly patient is having atrial fibrillation.
Yes.
Sir, in case of corrected transposition, we get usually, sir, bradycardia or complete heart block.
Okay, they can have. Why do they develop complete heart block?
Sir, there will be, sir, usually, sir, narrow QRS and, sir, heart rate around 40-50 because, sir, there is a transposition. No, sir, because there is a sir, loop.
Stretching of the AV nodal area.
Counterclockwise loop, sir. Sir, loop.
The bundle of his, does it normally run through the posterior aspect of the fibrous septum or perimembranous septum or anterior aspect? Yes, normally.
So normally posteriorly.
It goes posteriorly. And in L transposition or corrected transposition, what happens?
Sir, it will come anterior, sir.
And it goes anteriorly. And so when the AV node will not be able to establish a connection with the bundle of his, because the bundle of his is in a different location, and the AV node, which is developing normally, will not be able to establish a connection with the bundle of his, because the bundle of his is displaced. That does not happen in D transposition. Why?
Yes, sir.
Why?
Sir, because, sir, there the transposition is at the great vessel level.
Yes, the problem is at the great vessel only, where there is no change in the relationship of the left atrium, right atrium, the right ventricle, left ventricle. All those things are in the proper places, but the vessels are transposed. The pulmonary artery arises from the left ventricle, and the aorta arises from the right ventricle. So there is no problem of conduction. In transposition, L transposition, the bundle of his goes anterior to the perimembranous septum, and it will not be able to meet the AV node, and that will result in conduction complete heart block. And these patients, as you rightly said, they usually will have a narrow QRS complex. They can have conduction abnormality. Yes. So we don't think that the corrected transposition is a high probability. Anything else?
Sir, embryologically, this will be ventricular L loop, no?
Yes.
So, sir, that's why, sir, AV node and the bundle of his, they are not properly.
No, sir, bundle of his is in the anterior part of the.
So that is because of the L loop only.
L loop only, and because of that, it cannot meet the AV node. AV node, up to AV node, the development is normal, and the AV node will not be able to find the bundle of his, and there is no connection between the AV node and the bundle of his.
Oh, yes.
Okay, so these are the possibilities that we think that. So Jagadish, what are your first possibilities?
So first possibility I will like as atrial septal defect, sir.
Very good. Second possibility.
Second, small VSD, sir.
Why can't you consider mitral prolapse?
Sorry, sir. Mitral prolapse, second possibility, sir. Third is TAPVC.
Okay. or you can include small minor lesions like MR, AR, or a small VST. Okay, now anybody else would like to suggest any other differential diagnosis?
Sir, though less, but sir, we can think about abstain.
Or you think about the abstinence? Why do you think it's abstain?
No, sir, it's because sir, I think the pathology is on the right side. It's not on the left side.
Okay. Why
And
do you think
sir,
the pathology is on the right side?
because sir, no PND.
That's right, but she has not developed any edema of the lower limbs or nothing for you to certainly say that the right side is only affected. It may be because she is having okay. Somebody was talking. Can you mute yourself? Somebody who is not answering. Can you please mute yourself? Okay, Saroj, yes.
Sir,
Why do you think she's 78 years old female? What is the natural history of Abstinence anomaly?
sir, natural history is sir, like patient can present bimodal type of cyanosis, sir. Cyanosis will be at birth, and after that, sir, it will be either late after third or fourth decade. Patient again get cyanosis when RV fails.
Yes. The prognosis in patients with abstinence anomaly is decided by the
Sir,
RV function.
RV function.
If your RV function is well maintained, then these patients can continue to live. And the RV function is also decided by the severity of tricuspid valve displacement.
Yes, sir.
So there are case reports where the abstinence anomaly patients have lived up to the age of 80, but most of the patients usually succumb by about fourth or fifth decade.
Yes, sir.
Can they develop atrial fibrillation?
Yes, sir.
Yes.
But sir, more is pre-excitation.
Yeah, they can have atrial fibrillation, atrial arrhythmias can happen because of the dilated right atrium, and so those things can be explained. So we'll keep abstinence anomaly slightly low in the list, may not be top in the list. Okay. Anything else?
Yes.
Anything else? Okay, let's go to physical findings. Okay, Jagdish.
Yes, sir. On examination, patient is slightly obese, not dyspneic, not anemic. There is mild cyanosis. Hemoglobin is 18 gram %. O2 saturation of all four limbs is 89%. There is no clubbing, no edema of dependent parts. Pulse rate is 85 per minute, regular, normally volume and character. Vessel wall is not thickened. There is no radial or radiofemoral delay. Blood pressure is 150 by 80 millimeters of mercury in the right arm, right upper limb. JVP is not elevated. On deep inspiration, V wave is seen at the root of the neck.
Okay. So any help from the general physical findings, including JVP examination, blood pressure, pulse rate, pulse?
Regular.
No additional information.
No, sir.
All right. So shall we go ahead? Precordial examination.
Yes, sir. On precordial examination, on inspection and palpation, apex beat is not seen or felt. There is no thrill or sounds felt at apical region. No parasternal lift noted. There is an impulse felt in the third left intercostal space close to the sternum. There is no thrill or sounds felt at the base of the heart.
Okay. Now discuss at this level. From the palpatory findings, can you draw few any conclusions?
Third,
Do you think that
so there is only there is an impulse.
What about ASD? Do you think that this goes with ASD, or you feel that there is something which is not fitting in with ASD?
So the impulse felt at the third intercostal space.
Yes.
It's not matching, sir.
Why it is not matching?
Sir, it should be, sir, in the pulmonary area if I am thinking of ASD second intercostal space.
Okay. In ASD, where do you get the impulses?
Sir, pulmonary area. Left second intercostal
If the
space.
aorta, if the pulmonary artery is dilated, you can get the impulses in the pulmonary area. So lower down, can you get a parasternal lift? In ASD, can you get a parasternal lift?
Yes,
Sir,
sir.
when
Parasternal lift is present, sir.
isolmingarization,
No, why should
No,
you go
sir.
for
Before
isolation?
ISN mengerization also we can get, sir.
Jagadish,
Because of the volume overload.
wait.
yes.
Jagadish, can you explain the natural history of ASD? What happens in ASD? What happens in ASD?
Usually they will present with recurrent respiratory infections, sir. And isolmingarization will happen at third decade, sir. In third decade.
No. You tell me the hemodynamic changes that can happen in a patient with ASD as the age advances. Normally, in a patient with VSD and PDA, as the age advances, what happens to the shunt?
Sir, initially it was left to right, sir. And as it was maybe bidirectional or it reverses, sir, right to left.
Yes. So, in a patient with VSD and PDA, as the age advances with the development of systemic vascular resistance, systemic hypertension, the development of pulmonary vascular resistance, pulmonary artery hypertension, the shunt steadily comes down and it may become bidirectional or even right to left, resulting in cyanosis. Okay, right. So, in a patient with ASD, what is the pattern of shunt?
Sir, as the age advances, sir, left to right shunt will increase, sir.
Yes, there is in a patient with ASD, unlike the other two shunt lesions, the left to right shunt can progressively increase in patients with ASD. What is the mechanism?
Sir, because there is a development of systemic hypertension, increase in LV, EDP, so there will be more left to right shunt.
And you need not have any systemic hypertension. See,
Vascular resistance.
LV is a much thicker walled chamber than RV. So there will be more fibrous tissue. And as the age advances, the fibrous tissue content can gradually go up also. That will result in the compliance of the RV becoming much more than that of the left ventricle. Steadily, there is a reduction in the compliance of the left ventricle over a period of time, which results in a more left to right shunt in a patient with ASD. Jagadish, what is the mechanism which actually results in left to right shunt in a patient with ASD? What is it? Is it the pulmonary vascular resistance or something else?
Sorry, sir.
What is the hemodynamic parameter which controls the left to right shunt in ASD?
Sir, usually right side chamber compliance, sir, RV compliance side.
Yes, it is related to the compliance of the RV and LV, and it is the RV compliance, the much better compliance of the RV results in left to right shunt. As the age advances, what happens is that the compliance of the left ventricle comes down because the increase in the fibrous tissue, and some of these patients can have systemic hypertension, patients can have coronary disease, all those things. Even naturally also, the compliance of the LV falls more steeply than that of the RV, resulting in increase in the shunt. So in a patient with the ASD, the left to right shunt can progressively increase as the age of the patient advances. And that can result in a dilatation of the RV, the body of the RV dilates, the outflow dilates, and the pulmonary artery also, more blood is pumped to the pulmonary arterial system, the pulmonary artery also dilates. When all these structures dilate, what are the clinical findings, Jagadish? Where do you palpate the RV body dilatation?
There is a raised JLP, sir.
No. The question is, when the RV body dilates, the body impulses are felt in which intercostal space? Where?
Parasternal.
Fourth and fifth, left parasternal.
Left parasternal, fourth and the fifth intercostal space. RV outflow, where does the pulsations are felt?
The third intercostal space.
Third intercostal. And pulmonary artery pulsations?
The second
Second
intercostal.
intercostal.
So that's how it is felt. So the RV body, when it dilates, you can get good RV pulsations in the fourth and fifth intercostal space. When the outflow dilates, pulsations in the third intercostal space. And when the large volume of blood is going into the pulmonary artery dilates, you can sometimes get pulsations in the second left intercostal space. Okay. So tell me conditions where the RV body can be dilated. One is ASD, another is associated with tricuspid regurgitation, pulmonary regurgitation. The RV body can dilate and that can result in significant RV body pulsations, which will be felt in the fourth and the fifth intercostal space. Tell me conditions where the RV outflow can be dilated.
The abstinence anomaly.
Abstinence anomaly. Why in abstinence anomaly there can be RV outflow dilatation?
So because the septal leaflet of the tricuspid valve is lower down.
Okay.
As a result, there is a atrialization of the right ventricle.
Okay.
And so RVOT, sir, it is.
So that will result in less of inflow. The RV body comes down because
Yes.
it is the RV body which has been taken as the atrialized portion of the ventricle.
Yes.
That result in a very small RV body cavity. And when the RV body cavity becomes small, the blood coming to the RV is actually accommodated in the RV outflow region. And that will result in RV outflow dilatation. So patients with abstinence anomaly can have RV outflow dilatation with no significant dilatation of the RV inflow, and the RV parasternal pulsations will not be felt, while the pulsations will be felt in the third left intercostal space. Another condition where there can be RV outflow dilatation where the RV body will not be felt. Jagadish? Anybody? Any condition?
It be VSD, PDA, sir.
No.
Yes.
It will be more of a left ventricle which will be affected. And when they develop Eisenmenger syndrome, they can have a right ventricular hypertrophy, but that will not give rise to any significant parasternal lift. They can have a parasternal lift, but volume is the one which gives rise to very prominent pulsations in the parasternal region. Another condition where there can be RV inflow of obliteration and RV outflow dilatation is RV
EMF.
RV and the myocardial fibrosis. So the RV outflow pulsations can be felt because of two reasons. One, obliteration of the inflow part of the RV so that the RV outflow dilates. Conditions, abstinence anomaly and RV and the myocardial fibrosis. Two, large volume of blood coming to the RV causing RV body dilatation and also RV outflow dilatation. Example, atrial septal defect. It can happen in severe tricuspid regurgitation or severe pulmonary regurgitation. All can result in RV body as well as outflow dilatation. Okay. So here the patient is having no parasternal lift, but there is having there is an impulse felt in the third left intercostal space close to sternum. So we have to think of the conditions which can give rise to RV body dilatation. RV outflow dilatation. Okay, next, go ahead.
Sir, on percussion, dullness is percussed at left midclavicular line in the fifth intercostal space, and second right and left intercostal space close to the sternum are resonant. Right heart border dullness is percussed at 2 cm lateral to the right sternal bone.
What does that mean?
That RV is dilated, sir.
Yeah? Well, what is the evidence of RV dilatation here, percussion?
RV, sir, right atrium is dilated.
Yes, right atrium is dilated, or it can be also
Yes.
focal depression also, but more likely that right atrium is dilated.
Yes.
Not RV.
Yes.
You should be very careful. When the right border extends beyond the right sternal border, the chamber which dilates is
Right atrium, sir.
Not right
Yes.
ventricle. Okay, right. Yes.
Yes.
Okay, good. Auscultation.
On auscultation, S1 audible all over the precordium, feeble, best audible at the apex, S2 widely split, It moves with breathing, best audible at pulmonary area. It is normal in intensity. S3 heard at tricuspid area increases on inspiration, and an additional sound is audible along with S1 at tricuspid area. S4 ejection click, split S1.
You have to tell me of this of the additional sound which is the most likely.
S3. Sorry, sir.
You have to tell me an additional sound is audible along with S1. Is it an S4? Is it an ejection click? Or is it a split S1?
Sir, split S1.
Why?
The ejection click, sir.
You are saying ejection click. Why are you saying ejection click? Why Jagadish saying it is a split S1? Why are you saying it is a ejection click, Saroj?
Yes, sir.
What are the mechanisms of production of ejection click?
Sir, ejection click due to the semilunar valve, opening of the semilunar valve. That can be, sir, valvular, that can be vascular. Either because of the AV or pulmonary valve, or sir, maybe dilatation of the aorta or pulmonary artery.
The click can be either valvular or vascular.
Yes,
the valvular mechanism is mostly a doming of the valve secondary to stenotic lesion, aortic stenosis, pulmonary stenosis.
Yes, sir.
And the vascular click is related to the dilatation of the pulmonary artery or dilatation of the aorta, which can give rise to click. So in this patient, what is the mechanism?
Sir, here one more finding is important, sir. On deep inspiration, V wave is seen at the root of the neck. Sir, on deep inspiration, we are getting V wave. Sir, so it means that tricuspid regurgitation is significant.
Okay, probably during inspiration when large volume of blood is coming to the right side, the tricuspid regurgitation also becomes more prominent, and you are able to appreciate some wave in the neck, which may be a prominent V wave, or maybe it's a V wave. Agreed. Okay. No, but you are not answering my question.
Yes, sir.
Why did you say there is ejection click, and what is the mechanism in this patient?
Sir, increased flow through the pulmonary valve.
So you think that this is most likely to be a case of what are the conditions in which there can be increased flow of blood across the pulmonary valve?
Sir, like in case of ASD or VSD.
Yeah, there can, if they are considering ASD as a strong possibility, then increase in the volume of blood coming through the pulmonary artery, this can result in pulmonary artery dilatation, and you may be able to hear a ejection. Yes, but okay, that may be one reason, right? But do you think that it
sir,
can
but
be
not thinking, because sir, the S2 is sir, wide split, but it is variable, no, sir?
It is moving with the breathing.
Yes, sir. So S3 is heard at the tricuspid area. So, sir, we may have to think about endocardial cushion, endomyocardial fibrosis or Abstinence, sir, these two.
Yes. Now
Sir,
these
so
two, which one can give rise to an additional sound in the tricuspid area?
Sir, tricuspid area, sir, sir, more likely to be Abstinence, sir.
Why?
Sir, because in Abstinence, sir, we may get 4 sounds. One split S1, and sir, 2 more sounds. So 4 sounds are heard. One is split S1, and sir, one is, sir, I forgot the other 2.
What are the sounds which can be audible in a patient with Abstinence anomaly? You are right, but you cannot hear 4 sounds. You can hear
yes, sir. Split S1 and split S2 also.
Split S2.
Also third heart sound. You can
Yes,
get
sir, third heart sound.
the right side and third heart sound. So you can hear almost 5 sounds, split S1, split S2, and also a third heart sound.
So then it is split S1, na, sir. Then.
No, I do not know. You have to tell me. Then what is the mechanism of split S1 in patients with Epstein's anomaly?
Sir, because usually the interval between M1 and T1 is less than 30 milliseconds, so human ear cannot differentiate. Sir. But in Epstein's, the interval is more than 30 milliseconds, so we can appreciate M1 and T1 separately.
Why it is more than 30 milliseconds?
Because of septal, because of anatomy, septal, it is displacement of septal leaflet.
So septal leaflet of tricuspid valve is very long and flail. So it is hard.
Is it septal leaflet or some other leaflet?
The anterior leaflet, na?
Anterior leaflet.
Yes,
It is
sir.
anterior, and it is a sail-like anterior leaflet, and moves over a wide region. And when it comes in opposes with the other leaflets, already the mitral valve has closed, and there is a gap between the mitral closure and the tricuspid valve closure. It is because of the large flail-like anterior mitral leaflet. Sorry, anterior tricuspid leaflet, not the septal leaflet.
Yes,
The flail, or rather sail-like anterior tricuspid leaflet comes and closes the tricuspid valve with with the other two leaflets, and it takes time for the anterior tricuspid leaflet to move and close the tricuspid valve, and that is why in patients with Epstein's anomaly, you are able to appreciate the splitting of the first heart sound, which is usually more than 30 milliseconds. It may be even up to 100 milliseconds. Sometimes the gap between the mitral closure and tricuspid closure can be as much as 100 or even 120 milliseconds. So the gap will help you to differentiate between M1 and T1, and T1 will be sometimes quite loud also. Okay, right? Yes.
Yes, sir.
Why there is no change with inspiration or leg raising? If you think it's a right-sided problem, why it is not? There is no change.
There must.
Because functional cavity of RV will be less, sir, so it can't accommodate.
Very good. So
RV functions.
the large volume of blood is coming. It is not possible to accommodate more volume of blood in the RV because already a cavity is small. Already there is some degree of tricuspid regurgitation, and the patient is having already filled the right ventricle, and the volume of blood coming to the right ventricle on the right side cannot be accommodated in the right ventricle, and hence you cannot have a increase in the loudness of the murmur. So it is because the additional volume of blood coming to the right heart cannot be accommodated in the right ventricle. Okay, right. Yes, go ahead with the murmurs.
Yes, sir.
Sir, if we consider EMF, sir, it can be S4 also, no, sir.
EMF is very unusual to give rise to S4 because
S3.
S3 is possible.
Yes, sir.
S4
Because TR is present.
Yes, sir. S4 is unlikely because for a S4 there should be a sudden stretch of the ventricle. So here the cavity of the ventricle is partly obliterated and it's fibrotic, and there is no sudden stretch. So usually S4 is not a feature of endomyocardial fibrosis. More often, third heart sound is a feature of endomyocardial fibrosis.
Okay, sir. Yes.
Okay, right. Yes, go ahead.
Yes, sir. On murmurs, first there is a early systolic murmur which is low pitched, no change with inspiration, and leg rising at tricuspid area. It is of grade 2/6 intensity. And second is mid diastolic, low pitched rumbling murmur, which is increasing on inspiration and leg rising at tricuspid area, and there is no other murmurs.
Okay, now you discuss.
Yes, sir. First early systolic murmur because of tricuspid regurgitation, sir.
Why are you saying that? Why are you saying it's tricuspid regurgitation? No change with the inspiration, no change with the leg raising.
Yes, sir. Because RV, maybe because of RV failing it, sir, same mechanism as previous.
Yes, the RV is not able to accommodate anymore.
Yes, sir.
It is low pressure TR.
Is low
Low
pressure.
pressure.
Why it is early systolic? Jagadish.
So the early part of systole, only blood is regurgitating into RS, sir, and
Oh, agreed. I am
because of
asking why. That is because when there is a
The same mechanism, because the coaptation will take longer time. So
okay, and not coaptation will take long time. It is because it is a low pressure TR, and in the later half, because of the volume blood coming to right atrium, both from the systemic venous drainage as well as from the regurgitation, the right atrial pressure goes up, and practically the TR significantly comes down, and it becomes almost inaudible. There may be mild TR, but it becomes inaudible. So very often in a patient with Abstinence anomaly, what you hear is only an early systolic murmur. Okay. What is the mechanism of mid-diastolic rumble?
Functional murmur, sir, because
Yes,
of
it may be functional because of the increased volume of blood across the
Tricuspid valve.
Sometimes these patients with Abstinence anomaly.
The distorted tricuspid valve also present, and sometimes some stenosis may be present.
Very good, excellent. The valve can be slightly dysplastic, and it may have some degree of mild stenosis, and that can give rise to sometimes mid-diastolic rumble. Can you tell me the mechanisms of mid-diastolic rumble murmur? Mid-diastolic rumble murmur can occur in what all conditions?
sir, in
On the left ventricle, at the LV apex, what are the conditions which can predispose or which can create a mid-diastolic rumble at the apex?
sir, mitral stenosis, sir,
Mitral stenosis.
and
You have to say at least 6 conditions.
mitral stenosis, mitral regurgitation, mitral regurgitation.
I have to say the mechanism. Mitral stenosis is because of the stenosis valve. Mitral regurgitation
Because increased flow against the
like mitral regurgitation, ventricular septal defect, PDA. Okay, right, yes. Third
is myxoma, sir.
myxoma. 4
is AR Austin Flint murmur, sir.
Austin Flint murmur. 5
Caricum murmur.
Caricum's murmur. 6
So that Dox murmur.
Dox murmur is an early diastolic murmur.
Oh, sorry.
Due to myxoma.
Myxoma already mentioned.
Sir, Austin Flint murmur. Austin Flint murmur.
Austin murmur, I think somebody has mentioned that. For triatriatum? In patients with core triatriatum, you can get a mid-diastolic rumble. And did you mention Caricum's murmur?
Because of valvulitis.
Yeah. These are the different murmurs which can be mid-diastolic murmur, which can be audible at the apex. In the tricuspid area?
Tricuspid stenosis, sir.
Tricuspid stenosis.
And functional murmur because of flow, sir, in tricuspid regurgitation.
Conditions associated with increased flow across the tricuspid valve, as can occur in shunt coming to right atrium, like atrial septal defect, ruptured sinus vessel, a large volume of blood coming to right atrium, you can get. Then right atrial myxoma.
Yes.
Sometimes the aortic sinus, especially the non-coronary sinus, can project into the tricuspid valve and can result in relative tricuspid stenosis, or not relative. It can encroach on the opening of the tricuspid valve and can give rise to a mid-diastolic rumble. And also rarely you can get core triatriatum dextra, where there can be a septum in the right atrium, and that can also give rise to mid-diastolic rumble. So there are many conditions which can give rise to mid-diastolic rumble. Out of these, which is the reason in this patient?
Can we say Lutembacher, sir?
Lutembacher will not give rise to mid-diastolic. Why should, if at all, it can actually bring down the mid-diastolic? What happens to Lutembacher?
Tricuspid.
Increased flow. ASD we have already mentioned. All conditions where there is
Yes, sir.
increased
Yes,
flow,
sir.
especially in Lutembacher, you can definitely hear a mid-diastolic rumble across the tricuspid valve because of the torrential left to right shunt. Okay, right? Yes. So, putting all findings together, what do you think is your probability, Jagdish? What do you think is the lesion? What is your diagnosis? Are you there? Have you lost connection? Jagdish, are you there, or we have to ask somebody else to continue the discussion?
He is there, but he is muted.
Oh, he's muted. Jagdish, you unmute yourself and try to come to the diagnosis. Jagdish?
Now, sir, he is unmuted also, but still.
He's muted. Okay, and anybody who would like to?
Sir, what is this? Could you please repeat this early systolic murmur causing abstinence?
Yeah, it is because it is a low pressure tricuspid regurgitation.
Yeah.
Because there is no pulmonary artery, but it's a low pressure.
Yes, sir.
As soon as the LV starts contracting and the pressure builds up, the regurgitation occurs. That will give rise to early systolic murmur. It starts with the T1.
Yes.
Then
And
when
here desaturation.
Sorry, sir, I'm audible, sir.
Then when there is a large volume of blood is coming to the right atrium because of the regurgitation, as well as from the volume of blood coming from through the veins, what will happen to the V wave? What will happen to the right atrial pressure? It will steadily go up.
It will increase, sir. So, equalization
of
pressures early.
May not equalize, but the gradient between the right ventricular pressure and the right atrial pressure significantly narrows down, and the murmur becomes almost inaudible.
Yes, sir.
Okay. Yes, Jagadish.
Sir, here desaturation is because of low pulmonary RV forward outflow, sir.
There are many mechanisms. One, when these patients develop significant tricuspid regurgitation, yes, and the right atrium becomes bigger and bigger. If the patient is having an ASD, sometimes they can have a left to right shunt, right to left shunt. Yes. Or sometimes in these patients, as the intravenous septum stretches, the foramen ovale can, the foramen ovale can open up, and that can also result in right to left shunt. So these patients can become cyanotic because of two reasons. One, because of the pre-existing ASD, which occurs in almost 50% of patients with Abstinence anomaly, or it may be because of the opening of the patent foramen ovale. Yes. And this
can we say, sir, decreased pulmonary blood flow because of TR and forward RV outflow?
Well, that by itself, how much should be usually what should be the oxygen saturation for the patient to develop cyanosis?
Should be 92%, less than 92%.
Anybody would like to?
85%.
Sir, it depends on the who is seeing. The physicians are usually recognized as 85%.
Yeah, usually
and less.
Around 85%. Around it has to go around below 85% for detection of the cyanosis. So low cardiac output, well, it can give rise to peripheral cyanosis, but not the central cyanosis. Because of the low cardiac output, there will be more oxygen desaturation, more oxygen can be extracted from the blood by the peripheral tissues. But still, I would consider that in abstinence anomaly, even if the cardiac output is slightly on the lower side, cyanosis is not a possibility unless the patient has started developing RV dysfunction and shunt across the intrathecal septum onto the left side. Okay, Jagdish, we missed you. So, what is your diagnosis?
Sir, after examination, Abstinence anomaly is possible.
Eh?
Sir, my full diagnosis, sir.
Yeah.
Yes, sir. Cyanotic congenital heart disease. Abstinence anomaly, sir.
You cannot use the word cyanotic congenital heart disease. Maybe all right. Congenital heart disease with mild cyanosis. That would be, I would value is slightly diplomatic. Congenital heart disease with mild cyanosis, yes. Abstinence anomaly.
Patient Abstinence anomaly, sir, not in congestive cardiac failure.
Not in heart failure.
In
Yes.
Normal sinus rhythm.
Okay.
In NYHA grade 1 or 2, sir.
Okay, it was 2 symptoms because she is
with no evidence of infective endocarditis or signs of pulmonary hypertension.
okay, but the patient
The TIA.
yeah, patient had TIA, that has to be mentioned, and also patient had an episode of atrial fibrillation.
Yes, sir. An episode of TIA, sir, of weakness of left upper lip, and an episode of atrial fibrillation. She was on end.
She had not a very long, but a transient period of atrial fibrillation, and she probably settled
Yes,
down,
sir.
and that also should be mentioned. That also should be mentioned. Okay, so
Yes,
after the clinical, do you think there is a RV endomyocardial fibrosis?
Fibrosis.
The cyanosis is usually not seen. No?
All right, cyanosis also can happen depending upon whether the how much is RA dilated and all. But the most important thing is split S1 is not a feature of
RV endomyocardial fibrosis. Split S1 is specific
second
for
most.
And
Abstinence
sir,
anomaly.
also JVP, sir. In JVP, sir, we will get findings.
Yes, JEP in RV endomyocardial fibrosis, they usually will have a significant systemic
Prominent V wave.
yes, prominent VUS and JEP will be significantly elevated. And most of the patients with endomyocardial fibrosis, especially RV endomyocardial fibrosis, after the age of 20 or 25 will be in atrial fibrillation. So if the patient is not in atrial fibrillation, you must always consider whether it may not be RV endomyocardial fibrosis. Okay, so all possibilities are more in favor of a. Do you think that it is ASD? Jagadish? Do you think that this could be ASD?
Sir, if ASD, then sir, it is not a primum or secondum. It may be sir sinus venosus.
Why?
Sir, fixed split is not there.
What is not
Sir,
there?
as ASD is pre-tricuspid shunt, sir, there is no RV pressure overload features.
No, volume overload. See, in ASD, initially there is a volume
Yes,
overload.
sir. Yes, sir.
And then subsequently, when they develop pulmonary arterial hypertension, then only you can have pressure overload. So initially, volume overload. There are no features suggest RV body is dilated. So
Yes.
ventricular septal defect is quite unlikely. And what is happening to the second heart sound?
Is second heart sound is variable with respiration, but it should be fixed.
Yeah, second heart sound is widely split, but it is quite variable. So ASD, what we usually is that wide split, but at the same time fixed second heart sound. So all put together, the findings are strongly in favor of a diagnosis of atrial septal defect. Okay, what would you like to see? ECG or X-ray? Which one will give you immediate diagnosis?
X-ray, sir.
X-ray. X-ray will give you the diagnosis because X-ray can. What are the X-ray features which will help you to diagnose Abstinence anomaly?
Sir, RV dilatation, sir.
Very large heart.
RA dilatation is well picked up. Cardiomegaly. And sometimes you may be able to see pick up the RV body RV outflow dilatation also. And usually they will have a narrow pedicle because of the low cardiac output. And
yes.
the pulmonary vasculature will be either
Pulmonary bay will be more deeper, so it's less.
not be very deep, but not prominent, and the pulmonary vasculature will be significant, definitely much smaller. So let's look at the X-ray. Okay. X-ray, read X-ray and interpret.
Yes, sir. It's a chest X-ray, PA view, situs solitus, levocardia.
Why did you say that? Why did you say situs solitus?
Sir, actually there is like, yes, sir, stomach bubble is not.
No, you cannot make out. You should say that from this X-ray, I cannot comment about the situs. Whatever you cannot comment, you should make that statement. Here, I'm not able to make out whether
there is a cardiomegaly.
Yeah, cardiomegaly is there. Yes, very good.
No.
Right atrium is?
Sir, right, enlargement of right atrium is seen.
Yeah, there is a significant enlargement of the right atrium. Very good.
Yes, sir.
What about the pulmonary vasculature? Is it small? Is it enlarged? Is it plethoric? What is happening?
Normal, sir.
Normal, or if it is even much less.
Yes,
I won't use the word oligemia, but I will say that pulmonary vasculature is definitely much smaller, and see what you are seeing is very small vessels.
Yes,
very small vessels. So I would make a comment saying that the pulmonary vasculature is less prominent than normal, significantly less prominent than normal. And there is some suggestion that there's some
fullness is present, sir.
There's some prominence here, and this is the region where the RV outflow can be dilated. And if you are seeing a prominence like this, then always discuss that possibility that this could be an RV outflow dilatation. So the cardiomegaly, the right atrial enlargement, narrow pedicle, the pulmonary vasculature is actually significantly less than normal. And
the box shape.
There's a suspicion that the RV outflow is slightly dilated. All put together, the X-ray is suggestive of Epstein's anomaly. Okay.
Epstein anomaly.
Okay. What are the ECG findings of Epstein's anomaly?
Sir, here what can we say as apex, sir? What can we comment?
You cannot make any comment at all. If at all, it is more like an RV apex. I will not make any comment because it is definitely not LV. If at all the examiner compels you to give a comment, you could say that it's more likely an RV apex. But I will be very diplomatic in my answering, saying that the apex bit does not specifically characteristic of either the LV or RV type.
Okay, sir.
What are the ECG findings of Epstein's anomaly, Jagadish? What are the ECG findings? Anybody who would like to give a comment?
So P pulmonary.
Himalayan P wave.
Pulmonary, actually, some people have described it as Himalayan P wave. Very prominent P waves in the P waves. Yes. What else?
So pre-excitation type B.
Yes, sometimes pre-excitation maybe they're very good. 3. The second part of the QRS complex, which is a delayed part, sometimes can be very abnormal. So that can be an abnormal R' pattern can be seen in B1, which is also
fragmented QRS, sir.
Yeah, that also is very suggestive of Epstein's anomaly. Okay, let's look at the ECG also. Okay, ECG. Jagadish, read the ECG. Is there a Himalayan P waves?
No.
No. There are no Himalayan P waves, but P wave may be slightly more prominent than normal, but there is no Himalayan P waves. Yes. What else? Is there an abnormality in the QRS complex? Is there a conduction abnormality? Is there a WPW syndrome?
Sir, prolonged PR interval is there.
Prolonged PR interval is also one manifestation of Epstein's anomaly. What is the reason? Jagadish?
Because of right atrial dilatation.
Very good. It is because of the right atrial dilatation. They very often can have a prolonged PR interval. So this patient is having prolonged PR interval. That's the abnormal. The QRS complex is abnormal, especially the later half of the QRS complex. The delayed portion of the QRS complex is definitely abnormal.
Sir, one thing. So like I get confused when we do intracardiac ECG and sir we do the pressure tracing, sir, so that abnormal segment we will get sir whether RA type ECG will be like RV and pressure will be like RA.
Yes,
Sir,
that's
little,
right.
that's right, no, sir. Okay, sir.
That's right. You're right. We'll discuss that point.
Okay, sir.
Okay, right. So if there is an abnormal, there is no WPW. There is an abnormal. This ECG, not very classical of Epstein's, but was consistent with an Epstein because of the PR prolongation, abnormal QRS complex, and of course the P waves are not very large.
And
Okay.
the shape of the P waves are changing, sir.
Where is it changing?
Sir, leads to also.
Oh, there's some abnormality here. Okay. I agree with you. But I don't know whether it is a whether it is an artifact or not, because that is not seen anywhere else.
Sir, in the AVL also seen, sir. Though that is not the lead, sir. AVR also, sir. Both little change.
I agree with you. I agree with you. So the patient is having some ectopic activity, maybe atrial ectopy. Very good. You are right.
And sir, in all the QRS complexes, sir, in the top of the T wave, sir, some notch is seen, sir. Whether it is a 2:1 or not.
This one, no.
Sir,
This
in
is not a
all
P
leads,
wave.
sir.
No, that is not a P wave. That's
Sir,
part of the QRS
yes, sir.
complex.
Okay,
That's
sir.
part of the QRS complex. Okay, now we'll go to the echocardiogram and find out whether our diagnosis is correct or not. Okay, right. Interpret the echo. Jagadish,
Yes, sir.
you are not clearly audible. It seems that you are talking from a distance.
Yes, sir. Actually, sir, I'm in hospital.
Better, you are better now. Yes. Describe the echocardiographic findings.
Sir, left side upper, sir, parasternal long axis view, showing
what abnormality?
dilated RA.
How can you see the RA here?
No, sir. RV, I could say, sir.
Yeah?
Outflow. RVOT.
RVOT is dilated. RVOT is dilated grossly, and you can also
The
see
tricuspid valve is seen.
when the large anterior tricuspid leaflet can be visualized from everywhere. And so when you are seeing the tricuspid valve in the RVOT region, you must always, and RVOT is dilated, you must always think of Epstein's anomaly.
Yes.
Okay, then what else? What about the left ventricle? Is it contracting normally?
No, sir. Septal motion is paradoxical.
I don't know whether it is really paradoxical. I would have expected to be paradoxical, but I think there is some reduction in the movement of the septum, but I feel that it is moving in the direction of the normal septum. But the body of the LV is small.
Yes, sir.
But the ejection function is normal and its ejection fraction is perfectly normal.
Railway ejection fraction look normal.
It's normal. And in the
Yes.
M mode, what are you seeing? M mode, you can see that there is a
Yes, sir.
bit of the
Tricuspid valve.
tricuspid valve is seen. Okay,
Yes.
right.
Yes.
What is this? Jagadish, what is this?
Which?
So this is M mode of mitral valve and tricuspid valve seen. So the time gap between the closure of the mitral valve and the tricuspid valve. So
you can see this is the closure point of the mitral valve. This is the closure point of the tricuspid valve, and there's a big gap between the mitral closure and the tricuspid closure, which is as big as 160 milliseconds. Very big difference. Usually it is only about 30 or less than 30 milliseconds. Here it is almost 160 milliseconds. A significant gap between the closure of the mitral valve and the tricuspid valve is highly characteristic and diagnostic of Abstinence anomaly. So here you can see a gap between the mitral and the tricuspid closure, which is almost 160 milliseconds. Huge difference. Okay, right. So what do you find here? Nothing special. We'll go to the next one. Okay, what is this?
The apical displacement.
Apical four chambers.
Okay, apical four chamber view. What are the abnormalities that you find there?
Showing. Sir, displacement of septal leaflet more than it's quite prominent.
Yes.
And there is dilatation of right ventricular,
Yes.
right atrium, sir.
There is ventricularization, the atrialization of the ventricle, and so the atrium is very large. You can see the displacement here.
It appears, sir, more than it's quite prominent. Septal displacement, septal leaflet displacement.
Yeah, septal leaflet is
1.5 centimeters.
Yes.
0.8 centimeters.
If it is equal to 1.5 centimeters or equal to more than
0.8
by meter of body surface area, absolute 1.5 or more, and expressing
0.8, sir.
Oh, yes, very good. 8 millimeters.
Surface area. And so there is a Kalamazar index, sir.
It is equal to or more than 8 millimeters of per body meter square body surface area. Here the value is definitely abnormal. It is not oppressing at all. Okay, let us see. Okay, what do you find there? It is having severe
Tricuspid regurgitation.
Significant tricuspid regurgitation. You can see
Tricuspid regurgitation.
Gross tricuspid regurgitation, and the tricuspid regurgitation is a
and 2.3 meters per second. Sir, pressure gradient is 22.
Maximum
so low flow.
So it is a low pressure. Low pressure.
Low pressure here.
Low pressure.
Pulmonary regurgitation. So what is the diagnosis? Jagdish, what is
yes, sir.
diagnosis?
Yes, sir. Congenital heart disease, sir, which is congenital heart disease with mild cyanosis, Epstein anomaly, with severe Epstein anomaly, sir.
Severe
NYHA2 with no CCF, with normal RV function, with an episode of TIA, sir, maybe due to paradoxical embolism. With systemic hypertension and
he has got an atrial septal defect that we didn't mention. If you are careful here, seems that there is a defect here, and maybe a patient phenomenon or maybe a small ASD. That may be the reason that she's saying some degree of mild cyanosis, not very significant cyanosis, very mild cyanosis, and that may be the reason. She has got a grossly distorted tricuspid valve with the septal leaflet of the tricuspid valve is displaced into the ventricular cavity. Definitely more than 8 millimeters per meter square body surface area. The criteria are one equal to or more than 1.5 centimeters absolute or 8 millimeters per meter square body surface area. Okay, right. So now coming to description, Jagadish, you can read.
Congenital heart disease, cyanotic, Epstein anomaly.
Yeah, I am telling about the Epstein's anomaly description. You can read the description.
Congenital anomaly of the tricuspid wall characterized by tricuspid wall and associated wall dysplasia. In a good number of patients, posterior leaflet of the tricuspid wall may also be displaced. The anterior leaflet of the tricuspid wall is rarely displaced. However, anterolateral tricuspid wall can sometimes get
no, not anterolateral, anterior leaflet of the tricuspid.
Anterior leaflet of tricuspid wall can sometimes get added to the RV free wall, resulting in RV right ventricular outflow obstruction.
Yeah.
The
What is the
displacement of
problem
the
there?
tricuspid
No,
wall
don't go.
results.
No, don't go on reading. When the patient develops RV outflow obstruction in Abstinence anomaly, what is the problem?
The anterior leaflet of tricuspid wall.
Anterior leaflet tricuspid valve can get adhered to the region of the RV outflow and can result in RV outflow obstruction. What is the problem?
Decreased pulmonary blood flow, sir. This.
Okay, there can be decreased pulmonary.
Pulmonary hypoplasia, it may result in pulmonary.
Okay. Anybody else? Any other thought process? When there is a RV outflow obstruction, what will happen to the RV pressure?
Pressure overload will be
The
seen,
RV
sir.
failure will be very early.
Early.
Because of the RV pressure increases, and what will happen to when the RV pressure increases? What will happen to tricuspid regurgitation?
Increase and more cyanosis.
More severe,
it will be more severe. And patients with
and cyanosis will appear at the earlier age.
Patients with RV outflow obstruction, secondary to adherence of the anterior tricuspid valve leaflet, it will result in elevation of the RV systolic pressure, gross tricuspid regurgitation, and they become symptomatic quite early. So that's the anterior leaflet of the tricuspid valve will not be displaced, but it can abnormally get stuck to the RV outflow, resulting in RV outflow obstruction. Okay, right. Yes, go ahead. Somebody who has got a better connectivity can read, because I think Jagadish says, Saroj, can you read?
Yes, sir. Yes, sir.
The description of the.
Sir, the anterior leaflet of the tricuspid. Sir, from beginning I'll read. Congenital anomaly of tricuspid valve characterized by apical displacement of the septal leaflet of the tricuspid valve and associated valve dysplasia. In a good number of patients, the posterior leaflet of the tricuspid valve may also be displaced. The anterior leaflet of the tricuspid valve is rarely displaced. However, anterior leaflet of tricuspid valve can sometimes get adhered to the RV free wall, resulting in RV outflow obstruction. The displacement of the tricuspid valve results in conversion of part of the RV body, the inflow, functionally into the atrium, the atrialized ventricle. This results in functional RV body becoming smaller, and consequently the RV outflow dilates. Abstinence anomaly may be associated with PFO or ASD in 50% of the cases, and right-sided accessory pathway WPW syndrome in 25%. Other association include VSD, RV outflow obstruction, ventricular inversion or mitral valve abnormality. LV non-compaction has also been reported in Abstinence anomaly.
Very good. Okay, yes, go ahead.
Pathophysiology. Varying degree of tricuspid regurgitation, mostly severe. Occasionally, the dysplastic tricuspid valve can be stenotic, and these can cause significant RA dilatation. In view of apical displacement of the tricuspid valve, the right ventricular inflow is very small. As a sequelae to the small RV body, the RV outflow dilates, and if RA pressure goes above the LA pressure, then right to left shunt can occur through the PFO or ASD. This can result in varying degree of cyanosis.
Okay. So, what patients with abstinence anomaly can have cyanosis at different ages. Saroj, can you explain how these patients can be cyanotic? They can be cyanotic at birth, then no cyanosis, and later they become cyanotic. What is the reason?
Yes, sir. Sir, at birth, sir, there is a sir, pulmonary hypertension of the newborn is present.
Yeah,
So, sir,
okay.
sir, that's why, sir, sir, at the baby may have cyanosis at birth, but
No, 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 no. You have to explain it. No, no, that's not
yes, sir.
enough. At birth, the patient will have seen the pulmonary vascular resistance is elevated in newborn babies. So what
Yes, sir.
happens?
Sir, because the pulmonary vascular resistance is increased, so sir, the RV RV pressure
Hmm.
is increased,
Hmm.
and there is a ASD and PFO. So
Hmm.
sir, there will be right to left shunt. But
No,
when
you have to
baby
say one
breath,
more thing. You have to say one more thing. Because of the elevated RV pressure, there will be significant tricuspid
regurgitation.
regurgitation. That will result in acute elevation of the right atrial pressure, right atrial dilatation, and PFO can open up. AST can be there, and that will result in a right to left shunt, and the
Yes,
child can be cyanosed at birth. Then
yes,
what
yes.
happens?
Sir, when baby breathes, then sir, the pulmonary vascular resistance decreases. As a result, sir, the cyanosis will disappear because
Yeah,
sir, RV pressure decreases, tricuspid regurgitation will decrease, and no more right to left shunt.
very good. So that will result in disappearance of the cyanosis. Then what happens?
Sir, after that, sir, at a like sir, third or fourth decade or later, sir, later on, when sir, there is a increase in the uh, sir, because of this anomaly, sir, right ventricle fails.
Yeah, the patient can develop RV dysfunction,
Yes, sir.
and that can result in
Again, sir, that can result in again, sir, tricuspid regurgitation increases,
no,
RA
no, no,
pressure.
no, 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 no. The tricuspid regurgitation may not increase. When the RV fails and RV end-diastolic pressure increases, what happens? Right atrial pressure.
Sir, RA pressure will also increase,
Yes, because
and
of
then,
the
sir,
RV
again, sir,
dysfunction.
cyanosis will develop.
Yes, yes. The RV pressure increases. Here, the increase in RV pressure is not because of the tricuspid regurgitation. It
Okay,
is
sir.
because of the RV dysfunction.
Okay, sir. Okay, sir.
Okay,
Okay,
very good. Yes.
sir.
All right. Okay, that's the mechanism. Right. I will go to the okay. Unique clinical features.
So, unique clinical feature: no or mild or gross elevation of the JVP depending on the tricuspid valve dysplasia and RV compliance.
Okay.
No parasternal lift, RV outflow pulsation present. Split S1, the tricuspid component is loud, the sail sound. The tricuspid mid diastolic murmur present. No or varying degree of cyanosis present. So ECG, low
Okay.
voltage.
At any point, if anybody is having any doubt, you can always stop Saroj and we can have a discussion. But if things are clear, that's fine. Okay, right? Yes.
Sir,
Go ahead,
ECG.
Saroj.
Sir,
ECG.
ECG, sir, low voltage, tall and BJR, P wave. Sir, right axis
Right atrial
deviation.
overload. Hmm.
Oh, sir. Yes, sir. In L2 and V1 will show Himalayan P wave. PR may be prolonged, or in presence of WPD syndrome, the PR will be short with delta wave. The QRS can be BJR with RS R dash pattern in V1. The atrial arrhythmia can be present. Atrial flutter, atrial fibrillation are the commonest.
Okay, very good.
X-ray chest, cardiac enlargement plus right ventricular enlargement, narrow pedicle, RV outflow, dilatation.
Very good. Okay.
The echocardiogram, apical displacement of the tricuspid valve equal to or more than 8 mm per square meter of body surface area. In Plaque's view, the tricuspid valve can be seen in the dilated RV outflow. Both mitral valve and the tricuspid valve can be seen in the same view. The delayed closure of the tricuspid valve can be detected in MOD echo.
Okay. Right.
So, cyanosis. At birth, the newborn can be cyanosed due to the high pulmonary vascular resistance and significant PR and elevated RA pressure, resulting in right to left shunt to the PFO or ASD. As the pulmonary vascular resistance regresses, the right atrial pressure come down and the cyanosis can disappear as the right to left shunt decreases and disappears. Cyanosis can be more if the dysplastic tricuspid valve is stenotic. In the late adulthood, if the patient develops RV dysfunction, the RA pressure can go up and can result in re-establishment of right to left shunt and the cyanosis. Cardiac catheterization, rarely done in cardiac catheterization. The EA diagnosis can be confirmed by, oh sir, acha, this is what I was thinking, sir. The Abstinence anomaly diagnosis can be confirmed by atrial pressure with ventricular electrocardiogram.
Not electrocardiogram, electrogram.
Sorry, electrograms. Yes, sir, not cardiogram, electrogram in atrialized part of the right ventricle.
Yeah, that's the most important diagnostic point of in cardiac catheterization. You are getting a right atrial pressure, and when you record the intracavity electrogram, you will get a ventricular pattern. So ventricular pattern with electrogram showing a ventricular pattern and pressure showing a atrial pattern is diagnostic of Epstein's anomaly. This point should be very clear to you in the examination. Examiner can ask this point. Anybody who is having a doubt, you can ask now. I will once more clarify it. The most important point is right atrial pressure, the atrial pressure with ventricular electrogram. Okay, right. I think it's all clear to people, right? Very good. Yes. Okay. Management.
So management, as symptomatic, only follow up to detect any complication like arrhythmia. Indication for interventions are right heart failure, cyanosis, poor functional capacity, paradoxical embolism, or arrhythmias. Surgical treatments. Tricuspid valve repair. Most ideal treatment. Repair of the tricuspid valve is possible if the anterior tricuspid leaflet is not tethered to the myocardium, and ejection fraction, right ventricular function more than 35% of the RV is functional. Okay,
yes,
sir.
very good.
Tricuspid valve replacement, bidirectional cavo-pulmonary connection, Fontaine procedure if RV is too much hypoplastic.
If the RV is hypoplastic, you can go for single ventricle
repairs.
Fontaine procedure. And tricuspid valve replacement also is recommended.
Sir, always, sir, it has to be a biological, no?
Yeah, biological. It's a very poor substitute, but most of the centers where they undertake the Epstein's anomaly correction, they re-implant the tricuspid valve and do a total correction.
Sir, what is the difference between bidirectional cavo-pulmonary connection and Fontaine?
It's practically the same.
Yes, sir.
Okay, right. Yes.
Sir, surgical mortality in specialized center, the surgical mortality is less than 2.5%. Late death rate over 7 years is 7.6%. Catheter ablation is difficult. Success rate of the accessory pathway ablation is 80%. In expert hands, recurrence rate of arrhythmia is high, 40%, maybe due to the multiple pathways. Natural history is decided by the degree of tricuspid valve deformity and RV function. Patients with severe tricuspid valve dysplasia can die in utero or in early childhood. In adults, the RV function is the most important determinant of prognosis. Other determinants of the prognosis are degree of tricuspid valve dysplasia and cyanosis and presence of malignant arrhythmias.
I think that's all. So if you have got any doubts about this gives an overall picture of the Epstein's anomaly. Two, three important points you should know is that it is the RV function which decides the prognosis. And if the patient is having an early RV dysfunction, they have got a very bad prognosis. Two, Epstein's anomaly is amenable to surgical treatment. There are centers which can actually re-implant the displaced tricuspid valve, and these patients can do extremely well. The indications for surgery are the progressive RV dysfunction, the development of arrhythmias, and paradoxical embolism. All these are indications for intervention, and surgical treatment is the correct intervention. Those patients where the RV is reasonably functional are good candidates for complete repair. These patients with where the valve repair is not possible, then valve replacement could be done with the bioprosthetic valve. And the recurrent arrhythmia can be treated by ablation, but there is always a tendency for the arrhythmia to recur because of the multiple pathways. So these are the important points that you should know. And surgical mortality in specialized centers where they are undertaking only Abstinence anomaly surgery is as low as 2.5%. So this gives an overall picture of Abstinence anomaly, how to make the diagnosis and how to look at the X-ray and how to look at the electrocardiogram. So if you have got any doubt, you can ask now. If there are things are clear, that's fine. Any doubts? Is it clear how there can be atrial pressure with ventricular electrogram? Saroj, is it clear to you?
Yes, sir. Now I clear, sir. Yes, sir. Sir, one point only, sir. In the history, why this lady had exertional dyspnea during pregnancy?
What is your explanation?
Mm,
Maybe because she might have had some low cardiac output also, because she's a, or it may be even, may not be even, some of the patients, even normal people develop some dyspnea during pregnancy.
yes.
It may be functional. And she went through pregnancy very well. And also, she subsequent to pregnancy, she has lived for 45 years. She is now nearing 80.
Sir, it means it was not very severely displaced.
No, must be because the cardiologist who saw her did not advise any significant
Yeah.
medications and also told her that everything will be fine.
It's a very good case.
Sir, apart from split test one, sir, apart from abstain, other causes for split test one, sir?
I think very rarely you can hear normally also, but then the split test one, the T1 will be very faint. If it is a clear split S1 that you are hearing a clear T1, then you have to think of the possibility of Epstein's anomaly. What will happen to T1 in a patient with ASD?
Sir, it will be delayed, sir.
Why it is delayed?
Sir, because sir, the flow, more flow through the right side and less flow from the left side,
So
MB.
what? So what?
Sir, so
Which one occurs first, M1 or?
sir, M1 occurs first, T1 occurs
M1
first.
first, sir.
Why M1 is first? Why M1 occurs first?
Ventricular
Equalization.
pressure is more than right ventricular pressure.
So what?
So mitral valve closes early compared to tricuspid valve, sir, little bit because of force of contraction.
Now, one point is that because the LV is a more powerful chamber, so the rapid rise in pressure and the LV pressure can go above the LA pressure earlier than the RV pressure going above the RF pressure. Okay, right, one point. Two, which is the part of the ventricle which contracts first? Which is the part of the ventricle, right ventricle, left ventricle, all put together? Which is the part of the ventricle which contracts first?
Apex, sir.
Apex.
Right.
You might have done a lot of echocardiograms. Which is the part which contracts first? Of the it is actually the interventricular septum contracts first. Then after that, then then immediately there is a contraction of the papillary muscles. The papillary muscles should actually contract before the LV pressure increases. Why? It is the RV, this is the contraction of the papillary muscle which keeps the leaflets or the mitral as well as tricuspid valve together and prevents its prolapse into the corresponding atrium. So the papillary muscles contract. So if you look at the contraction of the ventricle, the interventricular septum contracts with the left ventricle. In a patient with ASD, what happens? When the right ventricle is volume overloaded, actually the septum can move with the
RV.
RV.
Level.
And in that situation, sometimes you may get the tricuspid T1 can become slightly early, and that will result in T1 and M1 occurring together, and you can get a loud S1 in a patient with atrial septal defect.
Yes. Okay.
Okay, all clear? I think abstinence anomaly can always be kept as in the examination, and this will give you a good summary of the abstinence anomaly, and you will be able to answer most of the questions that the examiners can ask you. Jagadish, any doubts? I think
No,
you
sir.
have
Thank you, sir.
connectivity so that you can take part more and more in the discussion. You should
Yes,
not
sir.
have.
Actually, I have not prepared. I'm in hospital, sir, so I connected. That's it. The network is not so.
Okay. 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 Good night.
Can you,
And,
sorry, sir.
yeah. Any doubt?
Sir, can you explain the last part again, sir, that volume over how they come together, M1 and T1?
Beg your pardon?
Sir, how M1 and T1 came together that you explained in AST, sir. Can you explain that part again, sir, please?
Yeah. Normally, the interventricular septum moves with the LV, and the LV pressure rises earlier than the RV pressure, and the crossover takes place early, and M1 occurs earlier than T1. And of course, there are other reasons like LV generates pressure much faster, much quicker, and that also results in an earlier M1. But in a patient with atrial septal defect, when there is a walling overloading of the right ventricle, how does the interventricular septum move? Doctor, what is your name?
Towards the left ventricle.
No. It moves paradoxically. When there
Moves
is
with RV.
moves
Yes,
with
ma'am.
RV.
Right.
And because it moves with RV, the RV pressure can start rising even along with the LV pressure or even slightly earlier, and that can result in T1 and M1 occurring together. Is it clear to you?
Yes, sir.
Okay, right. Yes.
Thank you, sir.
Thank you, sir.
Okay, right. Good night. I think well, next week
Thank
we
you.
have some spotters, and then only if anyone of you is having a case, please bring the case. That will becomes more lively. Please bring a case so that you can always discuss the case also. That will make the whole thing much more useful and much more energetic. Everything becomes much better. Okay, so next week there will be a spotter session, and following that we can have a case discussion. Okay. Okay. Good night. Good night. I think Jagadish, you discussed reasonably well. There have been some snacks here and there. You can improve upon it. I think Saroj, you did extremely well. I think you are very confident. You are talking very well. Your thinking is very good. I think you did extremely well. Very good.
Thank you, sir. Thank you so much.
Thank you, sir. Thank you.
Okay. Right. Bye.
So from here now I'm ending this meeting. Thank you all. Good night.